we'll be continuing our surgery recall January session for the surgery recalls from the FMGE exam. So in our last video, which we had published on 21st of January, we had discussed around 14 questions. So we will be discussing around 26 more questions as shared by you guys. Right, so there might be another few corrections in there as you had rightly pointed on our first video. So what we'll do is we'll come up with a corrected PDF version soon with for all of them. So let's begin our discussion for today. So first question for today is, which we have numbered the question 15, continuing from our previous session. Genetic testing for BRCA gene is done in all except, right, breast cancer in male, breast cancer in women age more than 50 years, bilateral breast cancer, or breast and ovarian cancer. So if you look at this chart which is given in the Bailey and Love, so it clearly mentions over here the indications for genetic risk evaluation, where the breast cancer diagnosed at age less than 50 years is your criteria and not breast cancer more than 50 years. So over here, this would have been your answer. Right. Then we have this next question, which of the following is true with respect to the image shown. So as recall from you guys, this image is your Fournier's gangrene, right? Fournier's gangrene. So what happens in this is, usually the testes are preserved. So it is basically a polymicrobial infection of the soft tissues of the perineum, right, and external genitalia and perianal region. Now what happens is that testes are usually spared as the blood supply usually originates intra-abdominally, right? So over here, the options which we got were the testes are preserved, necrosed, or increased risk of testicular cancer. So the best answer would be over here, testes are preserved. We do not know the fourth option exactly. So if any of you recall the fourth option, please feel free to comment on our YouTube channel, or you could share it directly with us. We shall include it in our updated PDF chart. Now moving down to the next question. Now, identify the image. So an image of this device was given and they had asked you like what it is. So this is a quite simple straightforward question. This is an image of a linear stapler, right? Now many of you told that it could be a circular stapler. So this is the image which looks like of a circular stapler, right? Now this image which is shown over here is an hemorrhoid stapler, right? Hemorrhoid stapler. So now you guys need to tell me which was the correct image which was shared with you guys. So as Maximum had told us this, so if this is the case, then it is a case of linear stapler, and if you had these two options in your exam, then it would have been a circular stapler or a stapler hemorrhoid stapler, right? Now the next question that we were shared was basically an image where a graft was done, right? And what options we got was this: isograph, xenograph, autograft, and allograft. So now you need to remember that isograph is done in between genetically same individuals, right? Then you have xenograph, which is between two different species, right? Two different species. Then you have allograft, which is from one individual to another. And then we have an autograft, which is in the same individual. That means I take a graft from one of the organs, like from my thigh, and put it at the other side of my own body. So the image which was shown as Maximum has shared was basically of an autograft, a split skin thickness graft, right? So this was also a chart from your Bailey and Love, right? So this is a definition of allograft, xenograph, orthotopic graft, and heterotopic graft. So in this question, most of you must have confused between the isograft and autograft. So remember, when the graft is taken from its own body, that is autograft and not isograph. Isograft is from one body to another body, and they must be identical, usually like in identical twins, right? So now the next image which question which was also shared to us was regarding the plan of treatment with an image. So this is basically an image which was showing an inguinal hernia. So it was a straightforward question asking you the plan of management for the treatment for inguinal hernia. So the treatment over here would have been hernioplasty, right? So we all know one of the standard repairs that we see for hernia is Lagenton mesh tension-free mesh hernioplasty, right? Then the next question was a 51-year-old presenting with a 2 centimeter breast mass and with axillary lymph node. Right, so now we do not know regarding the axillary lymph node status, so it would be very kind of you guys to share as whether it was a single lymph node or multiple lymph node or matted lymph node, because that would change your Tnm staging over here. Right, so now if you just go by it, this is absolutely a straightforward Tnm staging question. Now regarding the T, so basically T1 is less than 2 centimeter, T2 is more than 2 and less than 5. So now over here we have this as 2 centimeter mass, right? So it would basically go over here in T1 less than 2 centimeter, right? And now regarding the axillary lymph node, so if you see over here, it would vary. Now if it was an N1, it would have been a movable ipsilateral level 1 or 2 axillary lymph node. If it was a CN2, then it could either be a or a B, and in case its metastasis in ipsilateral level 1 to axillary lymph node fixed to one another or to other structure, or only ipsilateral internal mammary in absence of axillary lymph node. Right. So if you're seeing it's an axillary lymph node metastasis, then definitely it could not have been an N2B. Right. Now, in case of 3A, it is an ipsilateral infraclavicular, ipsilateral intermammary plus axillary lymph node, and 3C is an ipsilateral supraclavicular lymph node. So now over here we would want to know further details regarding this question to further classify the end staging for this. And regarding the M, as most of you told that it was no metastasis, so M would have been 0 in case of no metastasis, right? So this was a simple straightforward question from the Tnm staging of the breast cancer, and we have specified and discussed a lot many times in the class that one important Tnm staging for you guys to remember is Tnm of breast cancer, right? Now regarding the next question, a 39-year-old underwent laparotomy for peptic perforation. Now what is the most common complication? So this is one of the clinical scenarios which you all must have seen in regular in your internship postings. It is basically the surgical site infections or the wound infection that commonly occur after laparotomy. Then we had a CT image where it was showing the fused kidneys, right? So this was basically a horseshoe kidney. So we do not know the options yet. So if you guys recall the options, please share with us the other option. But as maximum of you have told, this was the correct, exactly the image which I have taken from the net that was shared with you, and this is an image of horseshoe kidney. Now the next question that was asked was, all of the following are causes of bilateral hydronephrosis except. So what were the causes of hydronephrosis? So now if you look over here, these are the causes of your lower urinary tract obstruction. Now if you remember, if you see, look at the kidney, if you look at the urologic system over here, you have kidneys, you have ureters, and you have bladder, and then urethra, and further on, right? So if there is any obstruction over here below, right, any obstruction over here below, it is going to cause enlargement of your kidneys. So it could be further classified into upper urinary tract or lower urinary tract. So now if you look over here, two of your options were phimosis and paraphimosis, which are your causes of lower urinary tract obstruction, right? Over here, as you see, phimosis and paraphimosis. Now the next questions, the two options that you guys shared was horseshoe kidney and ectopic ureter. The previous image that we had discussed over here was regarding the horseshoe kidney. So what happens in a horseshoe kidney is that there is the failure of the ascent of the kidney due to the presence of inferior mesenteric artery. So what happens is that because of this failure of the ascent, the kidney are not able to ascend up, and it is going to cause the bilateral hydronephrosis. Now in case of ectopic ureter, what happens? It is usually unilateral. And the question was asking you causes of bilateral, right? It is rarely bilateral. So in this scenario, the best answer would have been an ectopic ureter, right? Now, moving on to the next question, which of the following is the treatment of the image shown? So as you guys had shared with us, so basically it was a stone in your distal ureter. So over here, the answer would have been ureteroscopy, right? So it would be a ureteroscopy as your answer over here. Right, so if you look at the description of ureteroscopy over here, it would be the advances in designs of ureteroscopy have rendered the entire urinary tract accessible to endoscopic examination, traction, manipulation, are classified as rigid, semi-rigid or flexible. Semi-rigid ureteroscopes are frequently used to directly visualize ureteric calculi, right? And the stones are retrieved either by using wire retrieval baskets if it is less than 6 mm and in the distal ureter, or more commonly using lithotripsy employing different energy sources, right? So this question was basically asking you regarding the management, and it was most towards your distal ureter, so it is unlikely that it is going to be ESWL, right? And if you could share the further details of the question, it would help us further in framing the question and giving you a better answer. But as maximum of you have shared, the answer was ureteroscopy being in distal ureter, right? Then, which of the following is not a superior mediastinum tumor? So you had this options: thyroid, parathyroid, lymphoma, neurogenic tumor. So if you look at this image, the anterior and the superior mediastinum tumor commonly are lymphoma, thyroid and parathyroid, right? So over here, the answer would have been neurogenic tumor, because these are usually seen in your posterior mediastinum, right? So neurogenic tumors are more commonly seen in posterior mediastinum. Now, with the next question that we have is, which of the following has high risk of recurrence in duodenal ulcer? So some people have told us it is a low risk, some have told us high risk. So let's assuming that high risk, the answer would be directly coming from this table of Bailey and Love, where the recurrent ulceration percentage chances have given. So if it is a gastroenterostomy alone, the recurrent ulceration chances are maximum, which is 50%, right? And it is least in case of truncal vagotomy and antectomy. So over here, if it was gastroenterostomy alone, I would have marked the answer this. Now, if there are further any changes that you need to do it, so please share the further details of the questions and the other options, which would help us to guide you better. Now, features seen in all shock are increased peripheral resistance, increased heart rate, decreased cardiac output, decrease in tissue perfusion, right? The answer would have been over here, decrease in tissue perfusion. Now this important chart has been discussed with you guys plenty of time, so it's not true that there's an increased peripheral resistance all the time or increased cardiac all the time. Now if you look at the distributed shock, you have the systemic vascular resistance, which is low over here, and also the cardiac output is high in distributive shock, right? And regarding the decreased tissue perfusion, that's the definition of shock. It is a systemic state of low tissue perfusion that is inadequate for normal cellular respiration, right? So over here, the answer would have been decrease in tissue perfusion. Now moving on to the next question. A 45-year-old with a white patch in oral cavity, what will be the next step? So again here, it was a clinical based scenario, so we would want furthermore details from you guys in this question, right? So answer over here would have been biopsy. So if you look at this histopathological diagnosis over here, the formal biopsy is the gold standard prior to further investigation and treatment in the cases, right? So the answer over here would have been biopsy. Now moving on to the next question. A 60-year-old female comes to your clinic for a second opinion after total thyroidectomy for papillary carcinoma. What will be the next step? Reassurance follow-up, radiotherapy, chemotherapy, radioiodine scan. So if you look over here, the radioiodine scan over here is usually done, right? So you go in a state of high levels of TSH, following which you do a radioiodine scan, and if needed, then you go for an ablation, right? So this is usually what is done after your total thyroidectomy case of papillary carcinoma, to see regarding the residual thyroid cancerous tissue, if any, left behind. So over here, your answer would have been radioiodine scan, right? Now, a 35-year-old presents with history of renal stone, abdominal groan, psychic moans, and painful overtone. So this is a classical description of nothing but a primary hyperparathyroidism, right? So if you look over here, you have led to traditional pneumonic patients with primary hypertrophy present with bone, stones, abdominal groans, and psychiatric overtone, right? And the use of sesotime for parathyroid localization is now regarded as the most accurate and reliable method for imaging of parathyroid glands, right? So the answer over here will be sesotime scan. Now Moving down to the next question, which of the following is the management in a case of a homosexual person presenting with painful defecation and anal mass which is diagnosed to be squamous cell carcinoma? Right. The answer over here would have been a chemoradiation. Now this is again a straightforward line which is taken from your Bayesian law, which says that historically anal cancer was treated by APR, but now chemoradiation, that is the Negro regimen, has become the primary treatment. Right. So many of you told me that you marked APR, but no, it's Negro which has become the primary treatment. Now, few of you have shared this image saying that it was asked. Now, I do not know exactly what the options are, right? So, you have told that it was a case of a unilateral cleft lip. So, what happens in unilateral cleft lip are the muscle rings are disrupted on one side, right? Resulting in asymmetric upper lip on nose, which usually involve external nasal cartilage, nasal septum, and anterior maxilla, which is also known as premaxilla. If you have highlighted that it was asked regarding your premaxilla, and so we do not know, so please put in your options in your comment sections, and which will come up with a different answer to it if you have some different options for it, right? But it was some have shared just the image asking that what is the diagnosis. So this is basically a unilateral cleft lip, right? Then we have the next question that was asked with a diabetic patient presenting with diarrhea and migratory necrolytic skin rash, right, with severe weight loss. So what is the diagnosis? So if you look at this pancreatic neuroendocrine tumors, you will look at the glucagonoma. It has migratory necrolytic rash, glossitis, stomatitis, diabetes, severe weight loss, and diarrhea. Right. So this was again a straightforward question asked from your this chart, which we have emphasized it to be a lot many times to be important. Right. So your answer would be glucagonoma. Right. Next we had this image which you guys have shared. So we do not know exactly what were the options, but if this image was shared, it was directly taken from Bayesian law, which says it to be a capillary hemangioma, right? So if you have any other image or any other options, please share with us. We'll come up with the updated PDF version of it very soon. Now the next question that was asked was, which of the following is the treatment for MIBC? MIBC stands for muscle invasive blood cancer. So right, many of you have told we have marked mitomycin C, some have marked transurethral resection and surveillance. But let me tell you, the two primary radical treatment options for MIBC are radical cystectomy with urinary diversion or chemoradiotherapy. So if there was any other clinical clues in the question, then please do share. But from what the information that we have got, the best answer over here would have been radical cystectomy, right? Then it was another image based question which had come was regarding a 70-year-old which was presenting with gangrene and asking your diagnosis. So please remember, 70-year-old, history of heart disease, all points towards atherosclerosis, right? Now many of you told that why not Berger disease, so we are not very sure about what were the clinical scenarios given to you, but please remember, in Berger disease you have this criteria which is called the Shinoya criteria, which has usually between age of onset before 50 years. Smoking is a very important risk factor, and usually it is an upper limb involvement, and there's an absence of any atherosclerotic factor other than smoking. So over here you have your history of coronary heart disease, so which is pointing much more towards your atherosclerosis. Another very repeated and frequently asked question was infantile hypertrophic pyloric stenosis. So over here the main confusion that you guys have told were between non-bilious and bilious, right? The answer over here is non-bilious vomiting, and again these are straightforward lines from your Bayesian law, right? So it is occurring above the duodenum, and hence it would be presenting with a non-bilious vomiting. Then we have the next question with an alcoholic patient presenting with an epigastric pain radiating to back with amylase raise. A straightforward clinical scenario based question, which the answer would have been an acute pancreatitis. So these are again a straightforward lines from your Bayesian law. First in the epigastric region, but localized either to upper quadrant or fell diffusely through the abdomen. Then radiation back in about 50% of the patient. based on the clinical presentation and an elevated serum amylase level. Right. Now the next question was again, now some say to be a 55-year-old male or female, but the clue word over here was a thunderclap headache. Now some have also told that this was not the wording and it was rather the worst headache of life. So these are almost the same thing, right? The answer would have been over here a subarachnoid hemorrhage, right? Now another question which we came across was asking regarding the mastitis risk factors. Now we have not got all the options, but one option which you guys most have shared is regarding the cracked nipple, right? So if yes, the cracked nipple is definitely a risk factor. If you want to know the other options to know if they're asked regarding the most important risk factor, or it was just asking which of the following is a risk factor. So if you look at this line from Bailey and Love, right, so this microbes from the crack may enter the milk duct and may progress to lactational mastitis. So yes, cracked nipple is definitely a risk factor of mastitis, but now the other options are going to basically guide whether the cracked nipple would be the answer or not. Now moving to the last question, which is regarding on your fucrocytoma. So that asked you regarding a clinical based scenario where a 34-year-old presenting with episodic hypertension, headache and sweating, right? So the answer over here would have been a fucrocytoma. So if there are any other clinical scenarios or hints that were given, please feel free to share, right? So these are again straightforward lines from your Bailey and Love, right, which says 90% have headache, palpitation and sweating, right? So this was also discussed in our PYQ sessions, also in our YouTube channel. Now if you have any other questions, so there was something around 41 odd questions from your general surgery. Now if you have any other doubts or any confusion in the option, feel free to post it in your game website, right? You have your game Facebook club, you could share it as within the game app in Telegram, right, in Telegram, or you could directly put it in the comment section. So we'll come up with an updated corrected version with a PDF format and share with you guys. Now all the best for your results, and we are pretty sure from the team game that you guys shall do very well in an exam. And the beginners who are going to appear for the exam, just take a look at the standard of questions that have come. Like all of them have been mainly from the textbook of Bailey and Love. So I would definitely advise you to keep reading textbook of Bailey and Love, and rest keep following our YouTube channels and our Telegram app, where we often share the updates from your Bailey and Love. So all the best, keep reading, see you soon.